The next is about the acute abdominal conditions, and among them we mainly categorize the conditions like Shula, Gulma, and Antarvidriti and Udara. The Shula is a condition where there would be a pain at the area. Gulma is when there is a palpable mass but the structures are, and Udara is when the structures are involved. Antarvidriti is where there is a suppurative pathology where the pus is formed. Now these conditions can be attributed in any of the acute abdominal conditions, and we will have some examples of that sort. The definitions of that would be, of course, in Sushruta, these are not considered as consequences of the same disease. Instead, they are considered as separate diseases. Whereas in the present day situation, we keep them related conditions, like an appendicitis in the inflammatory conditions would be having that features of the Shula, and then when it presents with the appendicular mass, that's the Gulma, where there would be only the omentum which is adhering, and once the omentum is released, the things are normal. Or when it becomes an abscess, it is the Antarvidriti, or when it perforates and then leaks into the whole of the abdomen, it is the Udara. So this way the whole issue can be understood. Now we will try to highlight these issues with certain of the conditions, and the first of the condition would be appendicitis. Now appendicitis, of course, vermiform appendix, it's called as vermiform appendix because it has a shape like that of the worm, and it's well known that in the anatomy it's considered as a vestigial organ. Vestigial organ in the sense, from the original word description point of view, is considered to have no definite function, but I think it's not to be considered as a functionless, but the real functions are not known, and it has lymphoid tissues. Of course, it has a mucosal layer and a serosal layer. Unlike that of the intestines, there would not be all the muscular layers which are not present in the appendix, and it's presented at the tip of the cecum, and the positions would be either it could be ileocecal or retrocecal or subcecal or pre-ileal or post-ileal, and because it can vary, the position can vary, and because of these variations in the position, there could be variation in the clinical symptoms also. Retrocecal, the pain, when there is a pain, the pain would be, or the inflammation would be related to the posterior abdominal wall, and the muscles of the posterior abdominal wall would be involved. Whereas in case of the pelvic and ileal positions, the pelvic organs like the bladder could be involved, and hence the patient may have the symptoms related to the bladder or pelvis as such. In the subcecal and posterior positions, because the cecum gets involved, there could be increased frequency of the stools, so on. So there could be slight variation in the presence of the symptoms, particularly when the inflammation, appendicitis, reaches to the mesenteric surface, the outer surface of the area. Then because of the involvement of these different zones, the clinical presentation may slightly vary, and moreover, from the operative point of view, it's absolutely important to know about the different positions of the appendix so that you can search for the appendix easily. Anyway, the usual the pattern would be the tinea. If you follow the tinea, the confluence of the tinea coli, the three tinea coli, when they merge together, that's the point where the appendix originates, irrespective of the position. Anatomical variants of the appendix are quite common, and the appendicular blood vessels also are quite varying. Appendicular artery, which is a branch of ileocecal artery, but the pattern of the distribution of these arteries also can be wide varying, and these variations also are important from the surgical point of view. The common variants are like there could be a separate artery from the ileocolic branch, or there could be a separate branch for the cecum and the ileum together from the second arch. Either it could be the primary arch, or it could be from the second arch, or it could be the tertiary arch formation, which can be. So variations can occur, and from the surgical point of view, it's important to know about these variations. In addition to that, there could be many anatomical conjunction variations of the appendix, and the very common congenital type of the variations are now categorized as or classified as K-Valibridge classification, and The common varieties are either partial duplication of the appendix, where the initial part of the appendix there would be single, but at the tip there could be two branches or maybe more than two branches also rarely, or it could be like there could be a duplicated appendix, there could be more than one appendix, two appendixes, and it's also called as Berg type, where two appendixes are presented on the both the sides of the ileocecal wall, or the B2 is the other tinea coli type, where the two more than one appendixes may be present across the tinea coli at different points at the tip of the cecum as well as somewhere else there could be a presence of the appendix, or there could be a duplication of the cecum with the duplication of the cecum as well as the appendix. There could be two cecum and appendix, or there even could be horseshoe type, where the appendix could be curved and it may have two openings. And appendix also is supposed to be agenesis. Absence of the appendix is supposed to be, as per the statistics, it is present in 0.006% of the autopsies done, but the real population, how many of them, is not known. But in the autopsies done based upon the data, around 0.006% of the people would have agenesis. So from the clinical point of view, these are all important issues, because when you go for the operative procedure, these variations should be easily recognized. You should not miss the variations. Appendicitis is the again most common condition as such from the surgical point of view, and incidence of the appendicitis is approximately 233 per 1 lakh population per year, with a lifetime incidence of risk ranging from 6.7 to 8.6%. This is about the statistical data. And it's very interesting, the other issue is in the last few years, in the initial days, earlier days, appendicitis was more common in the Western countries, where the fiber content in the diet was very low. Whereas in the Eastern countries, where the fiber content is a common content of the diet, incidence of the appendicitis was lower. But now in the last few years, the incidence of appendicitis in the Western countries is getting reduced, because the people now are getting aware of the need of fiber in the diet, and the dietary factors are modified. Whereas in the Eastern countries, particularly in India, where the diet pattern is now shifting towards the Western fashion, and where the low fiber content diet is becoming the mainstay of the diet, incidence of the appendicitis is increasing, and it is attributed to the fiber content in the diet. And more common involved age group would be young age. The appendicitis, depending on the age group, in pediatric practice, of course, pediatric appendicitis also is one of the unique condition. Incidence becomes more at the age of 20 to 30. At that time it peaks, and then in the later half of the life, the appendicitis becomes less frequent comparatively. But at the same time, appendicitis in a very young age or a very old age would have its own specific complications. I will come to that part when we go into that. And the statistical incidence of appendicitis in India, of course, we do not have a very reliable data, but with the available data from the WHO base, in India, about 0.34% of the school age children and 0.25% of the adults have appendicitis. This is the available data, but actually this data is not very reliable. Now, as far as the appendicitis, the causes are concerned, the major cause is there could be some obstruction to the appendix, right? And obstruction to the appendix lumen can occur either with lymphoid hyperplasia, fecolids, parasites, or neoplasms. Neoplasms also can be present, and this is one of the important issue. Occasionally, particularly in appendicitis occurring in the older age, neoplasms could be very commonly existing, and hence every patient of appendicitis needs to be subjected to histopathology after the appendectomy. Then the other causes are, even without an obstruction, development of the resistant bacteria or hematogenous spread of the bacterial infection from some other source of the infection also can produce appendicitis. Common type of the organisms which are involved could be often gram-negative as well as gram-positive organisms are involved, and the most common and most harmful would be Escherichia coli or Yersinia. These are the two very critical organisms which can produce more severe conditions. Now, as per the clinical presentation, the clinical presentation of appendicitis is again often quite misleading. In the majority of the textbooks, lot of stress is given to the sign of Murphy's triad, where pain, fever and vomiting is considered as a mainstay of the diagnosis. But practically what happens is abdominal pain, of course, is the most common symptom of acute appendicitis. Nausea is seen in 61 to 92% of the patients. Anorexia is seen in 74 to 78% of the patients. Vomiting is always usually following the pain. First episode of the pain, there would be vomiting. Then after that, the pain precedes the vomiting precedes the pain, in the sense that vomiting occurring before the development of the colicky pain is suggestive of an obstructive pathology later, whereas vomiting occurring after the pain is suggestive of the acute inflammatory phase. So usually patients who present with the acute inflammatory appendicitis would have an episode of pain, then vomiting, there would be some relief. In later on, as the condition progresses, it results in obstructive pathology, patient would have vomiting and then the pain would be aggravated. So this change in the history also is quite characteristic. Diarrhea or constipation also can be seen as such in the appendicitis patients, and typically when the pain starts, the patient would have the pain starting at the epigastric or umbilical area. That suggests of the involvement of the mucosa, and then as the inflammation spreads from the mucosa to the mesenteric surface, the peritoneal surface, or there could be local peritonitis, the pain migrates to the right iliac region. And in a history taking, this time taken also is quite important. Usually it changes from the pain shifts from the umbilical or epigastric area to the iliac region by around 8 to 10 hours. Now, if that time taken is shorter, that suggests of an obstructive pathology where this infection is supposed to be more progressive, and it's one of the signs of an acute emergency where you need to be more alert in the treatment, or maybe more interventional treatment like surgery would be necessary. If the time for the shift of the pain from the epigastric or umbilical to the iliac region is less than 2 hours, if it is less than 2 hours, it's considered to be an acute emergency. Whereas in some patients it can even take up to 18 to 20 hours, though on an average it's around 8 hours is the 4 to 8 hours is the average time. And once the pain is there, unlike the other colicky pain, patient would feel like lying down without moving, and the hips are usually flexed and the knees are brought up to reduce the movement. Unlike that of the colicky pain of the pancreatitis. In the pancreatitis patient tends to bend forwards. Or colicky pain due to the renal colic or ureteric colic, patient tends to roll over the bed, moves here and there, whereas appendicitis patients would be avoiding the movement. Investigations or diagnosis is always quite difficult because there are quite misleading clinical symptoms over, and the same symptoms can occur due to multiple causes. And with all the sophisticated investigations, the recent data world over, it's not among only this, the world over, the statistics report that 1 of 5 cases of appendicitis is misdiagnosed, wrongly diagnosed due to other conditions. And it's also the other way, 15 to 40% of the appendicectomy done would be showing normal appendix, and particularly those who have undergone an emergency appendicectomy. In the emergency appendicectomy cases, a wrong diagnosis is quite common based upon the data, and it's based upon a widespread data throughout the globe, not only in India. So that possible errors are quite common. The common clinical test to confirm the acute appendicitis is the transmitted tenderness elicited. Transmitted tenderness elicited by Rousing sign. Rousing sign is when you press upon the left side, the patient would feel the pain on the right side. Or transmitted tenderness is simply a sign of local peritonitis occurring. And all the clinical tests now, you will have a series of clinical tests like Ilios-Obturator test or even Meckel's test or the Merkel's test or these cuffing tests also. These are done to confirm about the involvement of the mesenteric surface, whether and none of these tests would be positive in the early stages when the inflammation is limited to the mucosal layer. When it reaches to the peritoneal layer, then only these tests would be positive, and whole aim of these tests is to produce some movement at the area of the inflammation and whether that movement would aggravate the pain or not. In the early stages in the mucosal involvement, only the local tenderness pressing upon the area, that's the McBurney's test. When you press upon the McBurney's point is a point connecting the a point on the line connecting the umbilicus to the anterior iliac spine, interfered or interspersed at medial 2/3 and lateral 1/3 at that point. That's the point called as McBurney's point, and in majority of the cases of appendicitis, the tenderness is located at that point. And to confirm about that, the transmitted tenderness, either it could be Rousing sign where you press upon the left side and then see whether the pain is felt or not, or in retrocecal appendicitis, the iliopsoas test, because it is related to the iliopsoas muscle. Make the iliopsoas muscle stretched by extending the hip, and this external rotation of the hip would make the patient pain. Or obturator test, where the obturator muscle is made to contracted by flexing the hip and flexing the knee together, where the obturator muscle will be contracted, that would produce the pain. That confirms about usually in the retrocecal appendicitis, where the posterior abdominal muscles are in contact with the appendicitis, this inflamed appendix access, or cuffing test, when the patient cuffs, that again there could be pain, because that cuffing may produce a friction between the anterior abdominal wall and the inflamed appendix. Or the Merkel's test, where the leg is raised and then suddenly it's left out, that again produces same. So all these tests are to confirm about the transmitted tenderness. Now, as far as clinical diagnosis and the possibility are concerned, because the same symptoms can occur in multiple conditions, to confirm like whether it is really appendicitis or not by the clinical examination, you follow many methods, and one of that method is the Mantrel score. Mantrel score, where MANTREL, yes, these letters suggest about each of these. M suggests about migration of pain to right lower quadrant from the central abdominal area. If that is present in the history, then the score is 1. Anorexia, the score is 1. Nausea and vomiting, again the score is 1. Tenderness in the right iliac fossa, the score is 2. Rebound tenderness is score is 1. Elevated temperature 1. And leukocytosis, total count being raised, again 2. And shift of WBC to left, that is a polymorphonuclear leukocytosis. Polymorphonuclear cells are increased, then the score is 1. So total it makes 10. And if the score is more than 7, that confirms appendicitis. That's the usual pattern of making the diagnosis of acute appendicitis. Now, another way of guessing about appendicitis is based upon the leukocyte count. And the leukocyte count again is statistically analyzed, and the possibility likelihood ratio, statistical likelihood ratio is given as if the total count is between 4,000 to 7,000, the possibility could be statistical ratio would be 0.10, whereas when it comes to 17,000 to 19,000, the possibility is 3.5. 19,000 and above, it's considered to be infinite. So there you cannot make out like, and almost certain that it could be appendicitis when the patient has a history of pain in the abdomen and nausea along with the leukocytosis. That's about another standard method of making this diagnosis. The other investigation, of course, the importance of these investigations would be, if the WBC count is more than 10,500 cells, it would be seen in around 80 to 85% of the adults with appendicitis. So total count is one of the most reliable investigation parameter to make the diagnosis. Neutrophilia, that's a polymorphonuclear leukocytosis, is in around 75 to 78% of the patients. Less than 4% of the patients with appendicitis have a WBC count less than 10,500. So that neutropenia, reduced leukocyte count, doesn't rule out appendicitis, like the one which we had very recently. Recently we had one patient of appendicitis with very low leukocyte count, but still she had a very marked appendicitis. So that's an exceptional. But otherwise, total leukocyte count being raised and polymononuclear leukocytosis is one of the most reliable method of investigation. C-reactive protein is the other way. CRP is another of the usual investigation to be done. And in case of appendicitis, it could be higher as such, a level of more than 1 milligram per dl, and very high levels of CRP in patients indicate gangrenous appendicitis, which is again suggestive of acute emergency. And usually a CRP level become actually negative when the time duration of the onset and liver examination is more than 24 hours. Recently, one of the new method has been used, like urinary 5-hydroxy indoleacetic acid is now being used as an early marker of appendicitis, though this investigation still is not very popular. Maybe in future it can be quite popular investigation. And one of the other interesting part of the historical method of examination of appendicitis is earlier days a per-rectal digital rectal examination and vaginal examination was considered to be the benchmark to make the diagnosis of appendicitis. And till 2002, it was considered like if you do not do a per-rectal examination in case of appendicitis, it would be considered as a negligence. But statistically, later on, it was proved that per-rectal examination or per-vaginal examination would be leading to many misleading observations and errors as such, and hence now it's not included or it's not considered as an essential part of the examination. But only in patients who have appendicular abscess, suspected appendicular abscess, per-rectal examination could be useful. Now that's about the clinical examination and diagnosis of appendicitis. Of course, diagnosis of appendicitis also is done by imaging studies. In the imaging studies, plain X-ray is of virtually no use in making the diagnosis of appendicitis. Ultrasonography also has a serious limitation. The ultrasonography may not be used for confirming the diagnosis of appendicitis, but it can be used to rule out the other conditions which can have the similarity to that of the appendicitis. But an appendicular abscess can be better diagnosed with the ultrasonography. The recent or new ultrasonography machines with a high resolution can even identify a thickened appendix place of next stage. So as far as the ultrasonography is concerned, ultrasonography is not a very reliable investigation. Sensitivity of the ultrasonography is lesser. But if the ultrasonography confirms about the possibility is a thickened appendix, then it confirms appendicitis. But it will be useful, very useful tool, very reliable tool in case of appendicular abscess. If there is an abscess formation, ultrasonography is the investigation of choice. Whereas the CT scan and MRI scan are considered to be the other way. In the CT again now, helical CT, the trihelical CT is considered to be one of the benchmarks or a very suitable investigational tool to make the diagnosis as such. So CT has a diagnostic accuracy rate of 93 to 98%. USG is useful to rule out the other pathologies, most useful in abscess. Barium enema earlier was used as a tool of making the diagnosis, but now it's not used as a tool of making the diagnosis. Appendicitis also can be assessed in terms of the stages and the usual stages from the clinical point of view. We make the stages as early, suppurative, gangrenous, perforated, flammous, spontaneously resolving, recurrent or chronic. Early stage is where the patient comes to within 12 hours of onset of the pain. Suppurative changes do occur in due course of time when there could be a pus formation at the site and it could be in a later result in an abscess. Gangrenous changes occur rarely, very virulent infections or patients who have an obstruction, cause of obstruction in the appendix. Gangrenous changes can occur quite frequently, and the clinical evidence of the gangrenous changes would be high toxicity, and many times the total leukocyte count would be very high and CRP level also would be very high. Perforation of the appendix is one of the other complications which can occur. where the pain tends to spread into the whole of the peritoneum. There would be widespread peritonitis, the rigidity of the peritoneum and the tenderness presented elsewhere beyond the area of the right iliac area, right iliac fossa, also confirms with peritonitis. At the same time, the patient would have more toxic symptoms. Phlemonous or catarrhal appendicitis is when it becomes somewhat chronic, like a patient who has an appendicitis, it becomes somewhat chronic, and there would be more of vascular structures formed, and there could be partial obstruction, but not the gangrene, and it remains in the same stage for a long duration. Most of these conditions of phlemonous or catarrhal appendicitis would have some other soft tissue lesion like a tumor underlying, and hence in such conditions it has to be subjected to histopatology. Then spontaneous resolving is another of the condition where the patient may have a spontaneous resolution occasionally, which is unpredictable. Recurrent appendicitis is again a common issue. Once the patient has an appendicitis, even though it resolves or heals with your medical treatment, there could be some fibrosis, and that fibrosis can result in an obstruction, and hence the patient is having a high chance of recurrent appendicitis. Chronic appendicitis is a misnomer where the patient may have vague symptoms persisting for a long duration and not the other clinical signs, only there could be a tenderness, anorexia, nausea, etc. Abdominal symptoms could occur, and many times such conditions would improve once the appendicectomy is done, and that's how it is considered to be a chronic appendicitis, and that's one of the misnomenclature conditions. Now, as far as the treatment is concerned, in all appendicitis conditions, the benchmark of the treatment would be antibiotics of different sorts, and the choice of the antibiotics as per the antibiotic policy of ICMR. Now ICMR has given the antibiotic policy. The better choice is combination therapy of either cefazolin with metronidazole, or metronidazole is one of the common content of all the antibiotics used in appendicitis because of high incidence of the protozoal infections in the condition, and because of the gram negative and gram positive both involvement. Though the antibiotic policy suggests about these third generation antibiotics with the metronidazole, what I have found and what I have seen is the older antibiotic like gentamicin with the metronidazole would be quite more useful and having better results than this. But because we are discussing from the academic point of view, it's quite important to refer to the ICMR guidelines, antibiotic policy which is there, and according to that antibiotic policy, the choice of the antibiotics and their schedule is cefazolin 1 to 2 gram every 4 hours plus metronidazole, or cefuroxime or cefotaxime or ciprofloxacin or levofloxacin are considered to be choice of these antibiotics. And along with that, the patient may have to be maintained on IV fluids if the patient is not able to take up food properly. In an acute appendicitis, oral food intake may not be completely stopped unless the patient has a severe vomiting. This patient can be given oral semi-solid diet. That would be a better option than keeping the patient nil orally. Liquid and semi-solid diet can be given, and a good number of patients would resolve with the antibiotic therapy. If the patient fails to resolve to the this antibiotic therapy, surgery may be needed. Now, surgery could be of two sorts. Either it could be an emergency surgery, or it could be a planned surgery, or what we call as interval surgery. The emergency surgeries are indicated as per the general guidelines are in the appendicitis of very young children below 6 years, or appendicitis above the age of 70, or appendicitis occurring in pregnancy, appendicitis presenting with the signs of perforation or gangrenous stages, or appendicitis with a proved obstructive pathology. These are considered as surgical emergencies where the surgery has to be done immediately. If the total leukocyte count is more than 18,000, then too that's an indication for it's 16,000. If it's more than 16,000, there too the appendicectomy is suggested as an emergency procedure. In other conditions, it's better to manage the patient with antibiotic therapy and then plan for the interval. This is the universal guideline. Now, as far as the treatment, the surgical treatment is concerned, appendicectomy is considered to be standard tool of this surgery. And historical facts of appendicectomy is the first standard appendicectomy after making the diagnosis of an appendicitis was in 1880. Earlier to that, there could have been some appendicectomies done in patients of hernia surgery or some other accidental intervention of appendix was done, but a history of a planning appendicectomy surgery after having a clinical diagnosis of appendicitis was in 1880, and Lawson Tate is considered to be the first one who had done the investigation or the surgery for the first time. And then, of course, the history says 1886, a large study was published in the name of appendicectomy, and 1884, the Colin performs the first appendicectomy for acute appendicitis, but his patient dies. 1887, Morton performs the first successful appendicectomy for acute appendicitis, leading to patient survival. So, as far as the surgery, popularity of the surgery, the popularity of the surgery is just around 150 years old. Earlier to that, surgery was not done. And once the surgery became popular, history says, according to history, in German and Europe as a whole in Europe, there was a practice of a preventive appendicectomy before a person joins the army, defense services. And with an idea like this would reduce the possibility of medical leave application, because incidence of appendicitis was more common in the European countries at that time. But later on it was proved that appendicectomy, this preventive appendicectomy doesn't reduce the medical leave, that it results in some other complications, and the person would have some other disease condition, and the incidence of medical leave in the army was not reduced, and hence after about 3 to 4 years of that kind of a practice, it was actually stopped as such. Now, the other modified sorts of appendicectomies were done. In 1976, there was a colonoscopic appendicectomy which was done inadvertently. But 1980s, laparoscopic appendicectomy was practiced as a standard. In 2004, recently, Rao and Reddy, Indian surgeons in America, they have done the first appendicectomy by a natural orifice, the transgastric, that endoscopic through the stomach. The endoscope was pushed in and then appendix was removed. That was the latest. So the techniques of appendicectomy have been modified. These days, laparoscopic appendicectomy is gaining more popularity. But open appendicectomy is always the safer and better option. The open appendicectomy is, again, the approaches could be of different sorts. The incisions could be either vertical incision, horizontal incision, or oblique incisions. Oblique incisions would have always a advantage of cutting the lesser injury to the muscles. Muscles are split, whereas vertical and horizontal incisions would be cutting the muscles. But vertical and horizontal incisions give you a better access, whereas oblique incisions would produce more resistance, access would be lesser. So choice of these incisions would be based upon your experience and maybe the patient's condition. If you suspect an appendicular abscess, or if you suspect some adhesions or so on, then vertical or horizontal incisions are preferred. In a patient of an appendicular abscess, a median incision or paramedian incision also could be preferred, whereas otherwise a clean-cut case of appendicitis, an oblique incision would give you a better healing and better strength at the incision. As far as open and laparoscopic appendicectomy, the laparoscopic appendicectomy has a very little advantage in terms of even the amount of injury to the tissues, because you will have to have 2 or 3 ports. Single port laparoscopic appendicectomy also is now being practiced. But in all these conditions, based upon the statistics, I am just giving you the data of one of the review articles. Reference is here, where large number of these laparoscopic and open appendicectomies were studied in different centers all over the world, maybe more in the American and Europe countries. And based upon that, the advantages of the laparoscopic appendicectomy statistically were shown. Like the operative time for open appendicectomy was lesser than the laparoscopic appendicectomy, and it's quite significant. Bowel movements, recovery of the bowel movements in laparoscopic appendicectomy had taken more time than that of the open appendicectomy. And the time taken for the normal diet, laparoscopic appendicectomy, it had taken more time than that of the open appendicectomy. And parental analgesics, need of analgesics, not much significant, it's almost same. Oral analgesics, again almost same, like not much of a significant issue, or maybe slightly more in open appendicectomy. Hospital stay duration is slightly lesser in laparoscopy but not statistically significant. Return to normal activity in open appendicectomy it takes around 16 days, and laparoscopic it may take around 11 point plus that's the statistical findings of that. And the postoperative complications in these appendicectomy open and these laparoscopic, except for the wound dehiscence complication, rest of things is not, and wound infections. These only two issues were more in open appendicectomy, others is not very significant. But as far as the cost is concerned, laparoscopic appendicectomy at the end now, with all that individual costs as it, the total cost of a patient with the hospital mean stay in case of laparoscopy, it will be 2,965 in the European countries, euros, whereas open appendicectomy it will be 2,810 euros, significantly lesser. Now, about 5 to 10% of the patients who have a laparoscopic appendicectomy still need to have a converted to open surgery due to many other reasons, and this is about a retrospective study of 1,220 patients, another publication of that sort. So, as far as the real advantages are concerned, there is not much of an advantage. Now, variations of the appendicitis which we see in the operative findings would be, there could be an appendicular mass formation. Appendicular mass is formed when the omentum covers the area of the inflammation, and hence when you operate upon, you will find this mass, and then a lot of adhesions could be there. There you have to carefully search for the appendix, and the appendix has to be removed. Clinically, that would be presented, even can be presented as a palpable mass, and it has to be differentiated from a appendicular abscess. To differentiate that, ultrasonography would be always useful. Appendicular mass is usually formed after around 12 to 24 hours of onset of the pain, and if the appendicular mass is not formed even after 48 hours of the onset of the pain, then that condition could be considered as a serious, where patient may have some other pathology which can affect the immunity of the person, or in children and old persons and children. In children, because the omentum is not fully developed, appendicular mass may not be formed early, whereas in the older age, the this momentum would become less active, and hence it may not form the mass. In both the conditions, there is a high risk of a widespread involvement of the inflammation, and hence that becomes an indication for an emergency surgery. So, omentum mass formation is always an indication that the body's defense mechanism have taken care of, and the infection is limited. Even if the appendix gets perforated after the mass is formed, the chances of a widespread peritonitis would be lesser, the complication would be local. Appendicular abscess also often met with, like there could be either a pus containing appendix, or there could be a huge abscess. In such conditions, if the appendix structure is still not very friable, you may do the appendicectomy. Otherwise, if the appendix is very friable, better not to do the appendicectomy. Put in a drain and drain out the contents, treat the patient with an antibiotic. Maybe later a second stage appendicectomy may have to be done. Gangrenous appendicitis also can be often met with, where the whole appendix may become gangrenous. In that condition, appendicectomy has to be done, and the whole area has to be cleaned. Lavage is necessary because there is a high risk of widespread peritonitis. These are the modifications. A autoamputation of the appendix also is a very rare entity. Of course, recently we had one patient of this autoamputation, but in such cases, the appendix would be presented as a fibrous band-like structure instead of the tubular lumen, and that has to be removed. Adhesions have to be cleared, which is a very rare entity. The total reported cases of autoamputation are less than 0.002% as such. Rarely you may get that. Now, as far as the main preference of the treatment would be, surgery is indicated only when the total count is more than 20,000, or the patient has obstructive appendicitis obviously, or the patient has complications like perforation, or at times it could be choice of the patient's like. And otherwise, a course of antibiotics followed definitely and the Vijayakantharishta can produce a significant resolution. Chances of recurrence would be lesser. Number of surgical interventions can be reduced with this Arnithin and Bhairavi, and based the statistics of my patients seen in the span of from 1983 to 2019 till that period, the number of patients treated medically is increasing, number of patients treated surgically is lesser, and that's one of the important contribution. The patients now recognize that this is a situation where this is the center where the patient you can avoid surgery also. So avoiding surgery with our treatment, reducing the incidence of surgery, appendicectomy is also a contribution of the Shalyatantra as such. Now, a few of the other conditions which can mimic appendicitis, clinically often misdiagnosed. Most of the times, most common misdiagnosis of an appendicitis is mesenteric lymphadenitis, because the clinical features of mesenteric lymphadenitis are almost the same as that of appendicitis. And throughout the globe, 20% of the patients undergoing appendicectomy have been found to have non-specific mesenteric adenitis, and so errors of that sort are common. Now, it's of course, we do get a good number of patients of mesenteric lymphadenitis. It's due to a non-specific self-limiting inflammation of the mesenteric lymph nodes, often seen in the seasons of cold, like when the patients have cold and they swallow the sputum, inflamed sputum, the mesenteric lymph nodes they become slightly swollen, and as a result of that, the patient may have some pain and symptoms related to the abdomen, which can mimic that of the appendicitis, and this occurs somewhat seasonally. We see these patients of mesenteric lymphadenitis quite common in October, November, during that winter season. They are more frequently seen in our area. And the definition would be when the lymph nodes are more than 5 millimeters diameter in the mesenteric area, that's called as a lymphadenitis. The organisms which can produce lymphadenitis could be Staphylococcus, Escherichia, Streptococcus, Yersinia. Yersinia often they are more common now, and with the Yersinia, another of the issue is after the treatment the patient may have arthralgia. Tuberculosis is one of the conditions where the condition may become more chronic, which requires more longer treatment. Then giardiasis, typhoid also can occur. Occasionally viruses also. And majority of the patients whom we see of lymphadenitis are viral origin during that cold seasons of cold. It could be like Coxsackie viruses or rubella or even adenoviruses could be seen in such conditions. And it's a self-limiting disorder. Clinical presentation of non-specific mesenteric lymphadenitis will be abdominal pain, most commonly in the right lower quadrant, or maybe more diffuse, fever, diarrhea, malaise, anorexia, and respiratory tract infection prior to that is one of the common issue. Nausea and vomiting. Because of that, there could be always confusion with the appendicitis. And the other appearances, otherwise fever, patient may also have flushed appearance, the tenderness mild or without rebound tenderness. That's one of the important issues. There will be no rebound tenderness. And there could be a voluntary guarding where the patient may protect himself but not the real abdominal rigidity. Tenderness in the rectal area could be there. These nasal discharges, pharyngeal inflammation, toxic appearance also could be seen in conditions. A good number of patients may have a cervical lymphadenopathy. Total leukocyte count is usually not very high. Exceeding 10,000 is comparatively less common, and as per the statistics, it is seen in 50% of the patients. Ultrasonography would be quite useful to make out the diagnosis, where you can see the lymph nodes involved, even their sizes can be specified, and this also helps in ruling out a possible septic complications, which is common, which is not so common, but occasionally it can occur. So ultrasonography is a useful tool. CT also can make out the diagnosis of these mesenteric lymph nodes, their number can be counted. As far as the treatment is concerned, the generally supportive care like hydration or pain medication is good enough. and there may not be any specific treatment. Rarely there could be required antibiotic treatment. Complications which can occur would be volume depletion, like electrolyte imbalances in the patients with diarrhea and nausea, abscess formation very rare, peritonitis also very rare, sepsis also very common, very rare, and as I said, with Yersinia it could be arthralgia developing in the later period. These conditions can be better managed with the Agnitundi and the Bhairavi Diragadharista, considering them as a Shula. Then another condition which often mimics and produces confusion with appendicitis is Meckel's diverticulum. Meckel's diverticulum is a congenital variation of the growth of the intestines, this vitelline duct as such, and it could be presented in 2% of the people, 2% of the population, at a 2 feet distance from the ileocecal wall, and usually the size will be 2 inches, and there could be two types of heterotropic mucosa, that's commonly as gastric and pancreatic. One of the important issues about the gastric issue, and 2 years it may be presented in the age at which 2 years that it is presented, and the ratio is around 2:1 male and female ratio. The importance of Meckel's diverticulum could be of different sorts, and their pattern also could be different. Meckel's diverticulum by itself may be asymptomatic, but because of the presence of ectopic tissue over there, be it mucosal tissue of gastric origin, more gastrin hormone could be produced, and it could be a cause for the gastric irritation. In such conditions, the clinical diagnosis is quite difficult. Then the Meckel's diverticulum also can present with the different sorts of the connecting with the abdominal wall. Either it could be a simple band adhesion, or it could be a opening where there could be a umbilical fistula, or there could be a cyst presentation, or the whole thing may get torsion and present with the acute abdomen. Now these are the other conditions which may be presented with the Meckel's diverticulum. But one of the important issues is a Meckel's diverticulum may get inflamed. Diverticulitis could occur, and when the diverticulitis occurs, the inflammation occurs due to some obstruction over the area, then the clinical presentation would be exactly like that of the appendicitis. Whereas the other presentations may have a different sort of the presentations with the obstructive symptoms. Whereas the simple diverticulosis presents with the irritation in the stomach, where due to the gastrin hormone secreted, that the symptoms could occur. So only a few patients of Meckel's diverticulum may present with the diverticulitis, where the clinical presentation would be exactly like that of the appendicitis. Virtually it cannot be differentiated from the clinical point of view, and in such conditions the only treatment would be, when you open the abdomen you may find a diverticulitis, and the treatment would be, if necessary, diverticulectomy is done as a treatment. So that's about the other conditions. Of course, a few more conditions which can mimic appendicitis also are important, which we may discuss in the next session. We will wind up today with this. If there are any questions, I will try to answer, and then, right, there are not many questions, no questions as such, right, we will wind up today.